topic of interest will be establishing national oncofertility registries, experience from Australia, Germany, and Japan. My name is Yasmin Jayasinghe. I'm the Director of Oncofertility at the Royal Children's Hospital and the PI of the ANZCO Clinical Trials Network. So we have some stellar speakers tonight. Antoinette Anazodo requires no introduction. Of course, you know she's a pediatric and adolescent oncologist at Sydney Children's Hospital and the principal investigator of the Australasian Oncofertility Registry. We've got Dr. Kosuke Shigematsu, who is from the Department of Obstetrics and Gynecology at Saitama Medical Center, and he's recently published his work in Frontiers in Endocrinology on the Japanese Oncofertility Registry. And later tonight, we will be hearing from Dr. Dunja Baston-Büst, who is from the Medical Hospital University of Düsseldorf and head of the Department of the Cryobank for Fertility Preservation and assistant head of the IVF lab. And she will be talking about FertiProtect. So I guess the, national registries are very dependent on the sum of their parts. And just as an introduction, I was going to talk about our experience in Melbourne with the Melbourne Oncofertility Registry. So this was established in 2013, and it's a single centre registry at the Children's Hospital. And it was established to monitor long-term outcomes of fertility preservation. So the idea was that all children having gonadotoxic treatment with curative intent would be invited onto this registry. So we invite parents at the time of diagnosis, and when adult survivors turn 18, we get secondary consent from them. There's bidirectional flow of information from IVF labs, other registries, and just recently we're hoping to introduce a biobank component to this. And the idea, of course, is that the MORE registry will talk to future fertility run by Antoinette Anazodo. At the moment, it has around about 1,500 patients in it, and around 750 have had fertility preservation at our centre, around close to 300 testicular tissues and close to 300 ovarian tissue preservation procedures. So we did establish our key performance indices for quality of care quite early on. And being in a paediatric centre, our benchmark of care is fertility discussions, quality of consultations before the onset of cancer treatment. And so you can see that the registries really helped us to highlight our deficiencies in care. And when we first started, you can see in 2012, our documented discussion rates were, under 10%. But we managed to increase that with tools and guidance. But it was really only until we introduced oncofertility coordinated care that we had the kind of KPIs that we wanted to see. You can also see in that first graph that there was a huge gap in discussion rates in the absence of a coordinator. And we learned our lesson. So next time the coordinator went on leave, we had backfill, we were able to maintain our discussion rates. And so these KPIs have really helped us advocate for oncofertility care at our institution and for the resources that we need. Having said that, due to the impact of COVID and financial restraints, we've just modified our model of care to distributed care, meaning that the clinical teams within the hospital actually have their education in oncofertility and also administer these consultations. And we have had a reduction in our KPIs. We're working hard to reverse that through education. But without the registry, it would be very difficult to actually show the institution what we need. So if we did say that the idea is for us to put our data onto future fertility. Before the data gets there, there are so many barriers just within our institution alone. And I'm sure that many of you will identify with what I'm about to talk about. Firstly, data entry is, laborious, and getting funding to do that is difficult. Getting secondary consent from adult survivors is challenging, and we need to, revisit that model. Also, all patients referred to the Oncofertility Service do just about all of them do consent to come onto the registry. But we know that with the new distributed model, there will be a proportion of families that may not have fertility discussed, and we're working very hard to try and reach them, and we won't know their outcomes. Arrangements at IVF laboratories change. Data arrangements can change. Tissue storage arrangements can change. Registries, linkage with registries can be costly. And every time we introduce new components onto this registry, we have to think about legacy patients and how we consent them or not. And then, of course, with sharing with national registries, we need to think about data security, particularly if there's international data flow. And I wanted to highlight this paper, led by those in the consortium, and Mahmoud was, a co-author looking at national oncofertility registries around the globe and, the barriers to care, really. So last year, we did receive federal government funding for establishment of the Australia-New Zealand Consortium in Oncofertility Clinical Trials Network. And the idea is that we would like to improve digital connectedness between centres, would like to improve data flow between, for example, our medical records onto these registries. And we have already thought about the KPIs that we would like to collect within our region to monitor quality care. And we thought that the Australasian Oncofertility Registry would be the perfect platform for this. So I think this is a nice segue to introducing Antoinette Anazodo, who's going to be talking about the Australasian Oncofertility Registry. Thank you, Antoinette.
So thank you, Mahmoud, and to all my colleagues in the Oncofertility Consortium. I'm just going to load my talk. Hopefully you can all see that. Yeah. So yeah, I'm going to be talking over the next 15 minutes about my experience with Future Fertility, which is the Australasian Oncofertility Registry, although we do have other partners now. So the Australasian Registry was established in 2013 to house and capture patient demographic, cancer and fertility data. The idea was to have a prospective registry with oncofertility care where we could look at complications, access, and like the Melbourne registry, look at the reproductive survivorship complications. So in terms of our initial aims were to document the uptake and outcomes of the fertility preservation consultation process, to document the number of days from diagnosis to starting cancer treatment in those patients who'd had fertility preservation, knowing that there was a lot of data from clinicians that they felt that the timing and the potential delays in cancer treatment was one of the barriers for them. To document the complications in cancer patients, really being able to highlight, again, for cancer clinicians, the safety of fertility preservation, and to look at the particular models of care that needed to be implemented to ensure that fertility preservation is safe, and to capture the reproductive journey and reproductive outcomes into the survivorship period. So our registry is slightly different to the Melbourne registry in that it was initially designed to cover children, young adults, and adults up to 45 years of age. We wanted to include patients across that age group, but the ethics department was very, very hesitant at that time that fertility preservation was not necessarily standard of care for our prepubertal population, and that was before ovarian cryopreservation was made standard of care. And so they only allowed patients who were being referred for fertility preservation consultation to be part of the registry. So that was the sort of 0 to 12-year-olds. But for our 13 to 45-year-olds, we were able to recruit patients prior to being referred, so we could really understand at a population level prospectively what uptake and utilization was like. In terms of our population group, we were interested in any patient who had gonadotoxic drugs. So these were not only cancer patients, they also included our hematological patients, GI, rheumatological, and with the advent of new novel agents, a number of other disciplines have started referring patients. There are some exclusions, so we were only interested in the patients, so we haven't got information on the parents or siblings. They obviously had to consent. They had to have an interpreter if English wasn't their first language. We were not recruiting patients older than 45, and certainly there's been a lot of feedback about our male population, who we know was fertile, or the potential to be fertile at an older age, but we felt that we had to draw the line with the recruitment at some point. And in terms of our consent process, we had up to 180 days post-diagnosis for new or relapse patients. And that really came down to the work we did with consumers saying, well, they didn't necessarily want to be burdened with information at diagnosis, but would be very interested to be recruited at a later time. And so we felt that this gave us time for accurate data, but in a way that didn't put additional stress onto patients. In terms of consent, we really spent a lot of time thinking about what we were interested in finding out now and in the future, and hopefully making this consent quite a robust consent process, so that we wouldn't have to keep going back to patients to reconsent. So there were 5 different components: consenting for patients to personal data to be put onto the registry, and I'm going to show you what that data looks like. Consenting for the patient's medical record at both the cancer and fertility centres to be reviewed. And obviously, when you're thinking about oncofertility, it's really important to have both sides of that data. Potentially consenting for patients to be contacted for other research studies. So we wanted the Future Fertility to be a platform where there was opportunities for data to answer many different questions, and for these patients to potentially be involved in other types of research. And then thinking through what that research would look like, having potential to link the data. So we have linked it to the cancer registry, to the death index registry, and to the assisted reproductive IVF database. We also, in the future, want to see what the cost and health economics of having oncofertility care will look like as it becomes standard and implemented in all cancer centres. So we've also taken consent for health economics. In terms of the consent process, it's obviously different in the different age groups. So the younger, under 13s, was very much a parental model with assent required for the 13 to 17-year-olds, but with a hope that it would be age appropriately discussed with younger patients. Across all the age groups, there was a non-participation form, so we're really interested in why patients didn't want to participate, so that we can improve things if it was related to communication or the way in which the study was designed. As a revocation of consent if patients change their mind, and the Medicare consent had to be different because that was a Department of Health obligation. The login for our registry is can be found by going directly to Future Fertility website. And so it's a very easy thing to do. And we also had the opportunity on this website to have other information. So we've got various resources that have been specifically designed for future fertility, but also resources that we felt both nationally and internationally were relevant to our patients. So as a sort of hub for our patients to get info. So we felt that registration, as much as possible, we wanted it to be an easy process. We used the Salesforce platform, and we had as many drop-down boxes as possible. And I think the thing to say before I come to the data is that we spent a lot of time, probably about 2 years, thinking through how we were going to use the data and what data we needed. And then thinking about how we can ensure that as much as possible the data was validated. And so this first page is very easy in terms of demographic information. When we go to things like religion, ethnicity, indigenous status, for every country that has participated, we have really gone through and looked at how nationally data was collected so that we can ensure that if we were going to combine our data with other people, we would be using the same documentation. In terms of the consents, these are slide bars, so you're consenting for the registry, health economics, future linkage, and in other studies, and the person who did the consent just has to slide across, so it's very easy. And then for the health economics, we've got data on their insurance and Medicare item numbers. So you can see we've broken the registry down into sections. We didn't want it to be too daunting, so we wanted, the cancer physicians to focus on the cancer diagnosis or the cancer referral to a fertility provider, and then our IVF urology, reproductive endocrinologists to focus on their sections. And also we realized that this is a registry that hopefully will follow the patient through their reproductive lifetime. And some things like starting a family are things that would happen much later. So we really have divided it into sections that we hope make sense. So in terms of cancer diagnosis, we have information that again is done by our ICD-10 codes, and very easy to utilize drop-down boxes for this. In terms of treatment, we have put all of the protocols we've been asked to put in by our collaborating colleagues, and as much as possible to ensure that we've got the right doses, we've also gone back and ensured that we have information about the gonadotoxicity by putting in the protocols the patients had. So we've pre-populated for most of the studies that are collaborating with this registry. So in terms of cancer treatment, we're obviously not only interested in chemotherapy, we're interested in any surgery, any tissue, and there is specific pages for males and females to complete this. So that's the females. And then we move to the cancer specialist referral, where there's information about whether the referral was made, why it was made, and why it wasn't made. And that's detailed very easily, again, with the drop-down boxes. And then the sexual and reproductive health past information of a patient, and pubertal status. So then we go to fertility preservation, again, male and female information sheets, which detail the choices that the patient made and the outcomes, and we've detailed information on complications. And we've done that for males and females. And then there is information about, so that's follow-up, because we realise that there are some patients who don't have their fertility preservation straight away. So we're trying as an annual sheet to have information about whether patients have gone on to have fertility preservation, male and female sheets. And then for those patients who start a family, we want to know whether these are natural or IVF supported, and there's information on the fertility preservation. There's information about the assisted reproductive treatment these patients have and the outcomes from the baby point of view. So what are the benefits of this registry? Well, this registry allows us an opportunity to do national research. We've got collaboration in every state and territory and across paediatric, adolescent and adult centres. There is the availability of a very robust data set with 83 item numbers. As much as possible, we've utilised drop-down menus to reduce data input needs. And we've spent a lot of time trying to accurately calculate the gonatotoxicity with the protocols so the clinicians don't have to do that. We have seen, like Yasmin has said, how this data has helped to develop state funding and service development. So I think actually, this is very important data for us to collect. And as much as possible, we have validated the data or data items, which will allow us to collaborate with other countries. And already we are seeing that collaboration with our Indian colleagues, our American and our Mexican colleagues who have joined the registry. And, for those, we have made some adjustments. And like I said, collecting demographic and cultural information, it's really important to do that. Our difficulties, well, obviously, we went big with this project and it took us many, many years to complete the ethics requirements, the requirements of having a registry, so having data governance, to have data security and compliance. And we've had to develop policies for all of these. We've had to have champions in different centres, and as many centres didn't actually have models of care and referral pathways, you can see that the data entry in some centres has been very poor. So, while we want to have national data, I think it's a work in progress to try and get to that. Data input, obviously, we've realised that we have to have champions in each centre, and that requires some funding, which isn't always easy to source, and we have to have champions to consent patients, and then to re-consent them at 18, and so it really speaks to the time that's required for a study like this. And lastly, you need to have data accuracy, so you have to do regular audits to look at the data and to oversee the compliance to the data dictionary. So we also we've just finished the first paper with the first 1,500 patients, and since then we've collected a significant number of other patients. But I think the first paper will really demonstrate the uptake and utilization, the process of a developing registry, and the very low complication rates in those initial patients. So it's very positive. So I'm going to finish there just on 15 minutes. Thank you. I can't hear you, Yasmin.
Thank you, Antoinette. So now we'll move on to Dr. Kosuke from Japan. Thank you so much.
Okay, nice to meet you. My name is Kosuke Shigematsu. I work at Saitama Medical Center, one of the affiliated hospitals of Saitama Medical University. The hospital is located in Kawagoe City, Saitama Prefecture, with a population of 6.8 million and a far drive from Tokyo. With more than 1,000 deliveries per year, more than 1,000 surgeries, more than 400 egg retrieval, and more than 700 IUI. We are cancer center treating malignant tumors in the region and also one of the largest comprehensive perinatal maternal and child medical centers in Japan. It's also the lead hospital for fertility preservation in Japan, focusing on the JFR under the supervision of Professor Takai of our department. And today, I would like to talk about current status and issue of fertility preservation network in Japan. In the beginning, to start with background and aims. The graph shows cancer hospitals and earth hospitals clinics in Japan. Japan had 484 cancer hospitals and 17 pediatric cancer hospitals designated by the Ministry of Health, Labor and Welfare. In addition to 600 art hospitals clinics registered with the JSOZ. There are 125 centers, which are both MHLW designated cancer hospitals and JSOG registered art hospitals or clinics. Only 60 of which also conduct some form of FP. Similarly, there are 11 centers, which are both MHLW designated pediatric cancer hospitals and JSOG registered art hospitals or clinics. Only 6 of which also conduct some form of FP. Thus, the majority of cancer hospitals do not conduct art or FP. Next, show FP costs and registry in the major countries below. In 6 countries, the registration system has already been started, and in half countries, egg freezing costs are free. And there is also public financial support for egg freezing and ovarian tissue freezing. But in Japan, there are no registry and few public support for FP until 2017. So in 2017, the Japan Society for Fertility Preservation, JSFP, set up a registry committee which comprises of not only doctors specializing in reproduction medicine, oncology, and pediatrics, but also oncology nurse, a lawyer, a psychologist, and patient representative. JSP has launched the Japan Oncofertility Registry, JOFR, in 2018, which will collect an oncofertility data set from FP hospitals and clinics in Japan. This table is the data dictionary of JOFR. A large number of data related to fertility preservation are registered, as shown in the data in this table. The registered data was then analyzed to determine the number of enrolled patients, basic information, and reproductive findings and outcomes during follow-up, such as remaining reproductive function and pregnancy. This graph illustrates the Japanese Ministry of Health, Labor and Welfare Research Promotion Project, which began in April 2021. The Ministry of Health, Labor and Welfare, Japan MHLW, launched a project for promoting research on FP in April 2021. The facilities must register the patient to an updated version of the JOFR in which National Cancer Registry did and patient-reported outcomes are integrated. Since the JSP requires facilities to register patients who do not receive FP therapy in the old JOFR, we believe that this project contributes to the expansion and diffusion of both types of JOFRs. Currently, the new JOFR is in the process of starting to operate, and did up to 2022 will be used to clarify the details of FP medical care provided in Japan. One new addition to the new GFR is an electronic platform for PROS called ePro, through which enrolled individuals can update their record using their smartphone. This setup allows both patients and healthcare providers to furnish and verify the GFR data regarding patients' general health status and reproductive function, including pregnancy outcomes. Patients who received counseling or FP procedures before April 2021 or those who did not undergo any FP procedures were registered in the old GFR. Both old and new GFR are integrated in the upgraded registry system called the GFR2, which has been fully operated since August 2022. Comparison of old and new GFR is that old GFR is registered in all cases before March 2021 and cases not eligible for public subsidies after April 2021. And the new GFR registered is that cases eligible for public subsidies after April 2021 cases eligible for public subsidies. The only difference between the old and the new GFR is almost the presence of patient application. This shows how to register a patient application. Patients are requested to download the application themselves and enter their information. The table shows the smartphone patient application FCS link, basic patient information, prognosis, and reproductive evaluation, and fertility preservation details, and pregnancy outcomes, and so on. These figures show the number of patients enrolled in the GFR by year. Although the number of cases has increased each year, the result are through 2022, as many facilities have not yet enrolled patients for the year 2022. A total of 9,397 cases have been registered until now. From this section, we present the registered patient. This graph shows the age of GFR registered patients through 2022. Males are almost evenly distributed with the highest percentage, and males are also almost evenly distributed with the highest percentage between the age of 26 and 30. Percentage of mean leukemia, testicular cancer, and myeloma are the three most common primary diseases in male cases, while breast cancer accounts for 2/3 of female cases. This graph shows details of frozen sperm registered in the 2022 in the GFR. The number of patients registered to date is 3,781, and the number is increasing every year. The following table shows the number of tested cases registered in the GFR through 2022. The number of cases varies from year to year, but is generally around 10 cases for a total of 61 cases. This graph details the cryopreserved oocyte fertilized eggs registered with GFR through 2022. In 2020, there are 222 cases, and some cases have not yet been registered. But this number is increasing due to the subsidies. The total number of cases is 1,464. This graph details the cryopreserved oocyte unfertilized oocyte patient registered in the GFR in 2022. This is also expected to increase for the same reason. The total number is 1,870. through 2022. A total of 378 cases have been registered so far. Further increases are expected in the future. Among the total 9,612 GFR registered patients, 574 experienced subsequent pregnancy. In conclusion, continue to maintain the old and new GFR database to disseminate information on prognosis, pregnancy rate, and other oncofertility outcomes in Japan will contribute to the further expansion of oncofertility service in the country. Thank you for listening. It was my pleasure to be here. Thanks.
Thank you so much, Dr. Kosuke, for that very lovely presentation and outline of your registry. And now we'll move on to Dr. Dunja Baston-Büst. Thank you so much for joining us, and I'll let you take the floor. Thanks.
Thank you very much. So this is the talk. Okay, then, thank you very much for this kind invitation, and I'm looking forward to talk about the German registry. And I really see very many similarities to the Australian one, so let's see. I'm going to talk about our network. So we've got a network that is called FertiProtect, as the abbreviation for Fertility Preservation Network. And I will talk about the data set and the presentation and publication of the data. So FertiProtect was founded in 2006. We've got a member fee for each center, and it was voluntary, and it's still voluntary. And it started with less than 10 centers in Germany, Swiss, and Austria. So these are the German-speaking countries. And now we've got about 158 centers that are members. The patients can find a list of centers on the homepage of FertiProtect. So if they need to be referred to a specialist, and there are special schedules, for example, for these patients. The members of the network, as well as the editorial board, are authors of guidelines, books, workshops, and meetings. And one of the most popular you can see here on the right side. So it's a very practical book where oncologists, for example, can look what they can talk to the patients already before they are referred to a specialist. We collect data about the treatment in female patients. So FertiProtect is focused on female patients. And for the male ones, it's called AndroProtect in Germany. But it's just at the beginning now. We've got 3 centralized cryobanks for ovarian tissue, and oocytes can be frozen in every infertility unit in the German-speaking countries. So there are no limitations. I will give you an example for a tool that was created for the counseling. You can see it's traffic and for gonadotoxic effects or risks. And we divide them in low risk and intermediate risk and high risk. And patients are referred to the specialist up to 40 years. So the conditions for a registry are, and have an impact, are the size of the country, the numbers of centers, especially the density and the area coverage. So for example, in Düsseldorf or in North Rhine-Westphalia, where we are located, we've got about 10 IVF centers here. But compared to the north, for example, there are really less centers. The centers need a willingness to cooperate, and you need responsible persons. For example, a responsible physician or a responsible biologist. And there are different political and financial conditions and burdens in each country. And for example, the reimbursement was introduced in Germany for M2 oocytes in July 2021. and in July this year for ovarian tissue. We need to divide the patient into private and statutory patients, unfortunately. And the register itself needs financial support, so there is a third-party funding also next to the member fees. And what we need is patient information and patient consent, obviously. So we started with a mandatory questionnaire for the female patient, and the data we collect are the initials of the patients, and they get a Ferti Protect ID. So we call it a Ferti Protect ID to easy out the follow-up. We've got the age and the date of birth, the date of counseling in the center. We ask if there are children already and if the patient is married or not married. We collect the data about the diagnosis and if there are any other gynecology pathologies, and also the AMH level. Furthermore, the treatment which is planned, for example, chemotherapy or radiotherapy or surgery, and the fertility preservation plans. So if the patient wants to freeze M2 oocytes or ovarian tissue or transposition of the ovary, which is very rare in Germany, for example, or collect 2PNs or just inject GnRHA or any combinations. So the register, and I think that's similar to the others too, just started as a one-man show in 2006, and then it grew. So there were more and more cooperating centers, and an online tool was designed with a questionnaire. And now parts of the fertility treatment are incorporated in the National IVF Registry. And the Ferti Protect ID is also included in the IVF Registry. And the data were first presented on the Ferti Protect meetings. And now they are just really part of the National IVF Registry and presented in the annual report. Now I'm going to show you some data of the publication in the annual report. So we collect the data about the consultations and the interventions, and unfortunately the number is still very low, I think. So we've got in 2020 about 1,500 consultations and about 1,000 interventions. Here you can see the age distribution. So we collect data even in the pre-pubertal and in the child up to 40 years. And most of the patients, so female patients, are diagnosed with breast cancer, lymphomas, leukemia, other malignant tumors, and some of them also with benign diseases, for example, endometriosis. Here you can see the data for ovarian tissue. So the numbers on the left side are the ones that are frozen for later transplantation, and on the right side, these are the numbers for the ovarian tissue transplantations that were performed up to 2020 in Germany, for example. We also tried to collect all the data about ovarian tissue and about the shape of the ovarian tissue after transplantation. And here are the success rates in the different age groups. And we all know the younger the patient, the better the results. And here you can see the endocrine activity per transplantations, and the younger patients, it's nearly about 80%. And the pregnancy rate is also very good, so it's comparable to ART treatment. And we are very proud to have this data already. Now about the financial aspects I already mentioned. So by July 2021, the reimbursement started for M2 oocytes and also for sperm or TZ in the male. And the health insurances only pay for M2 oocytes in female patients with that are hormone receptor negative, unfortunately. And they pay for sperm and TZ. And ovarian tissue is now also reimbursed but very low reimbursed. So we're not very happy about that. And we already started now clinical studies in the pediatric population, which are also included now in a questionnaire, and some of them also get financial reimbursement. So current challenges and future directions. So we need better follow-up for M2 oocytes and for agonist treatment and transposition. Unfortunately, we've got no connection between the cancer registers for juveniles and for adults in Germany and FetiProtect. We've got no data exchange between the juvenile and the adult registries. And we've got a big lack of male data, unfortunately. And we've got new therapeutic schemes that are observed. And now we've got an ethical approval to perform these studies and to look at the data we can collect now on. Thanks for your attention.
Thank you so much, Dunja. That was a fantastic presentation. So we've had 3 really excellent presentations from around the globe. I just have to ask if there are any questions from the audience. I'll just open the chat and you can type them in the chat as well. So while we're waiting, I think, I might ask, all of you, I mean, what do you think were the biggest barriers to setting this up? And I know that you could name so many, but what do you think is the biggest hurdle, and how did you get this far with this much buy-in from your collaborators? Maybe Antoinette, you can go first.
Oh, thanks, Yasmin. Well, look, hard to know. I think probably it's deciding what the reach is for the registry. I think in retrospect, we probably were too keen to make it national too quickly, and we should have probably just started in 1 or 2 centres to see how it was going, and from then slowly build up. I think the ethics, or having ethics or ethical processes are obviously great, and it ensures that we have the right governance, but it's a time-consuming process. And when you're doing it on a large scale, you have to factor that in. So I think having enough support from CRAs and, other administrative support, I think was important, and something we really didn't have enough of. And I think there's the ongoing support that's needed for registries, because every ethics have their own annual reports, and you can be really waylaid by the reporting side without actually focusing on the data side. So I think that's, also part of the problem.
Thank you so much. I can fully identify with that. What about Dr. Kosuke?
I think in Japan, the number of registrations was small at first. But now, before I choose, the total number is around 9,000, about 9,000. However, Dr. Suzuki and Professor Takai and his team have been able to raise funds to increase the number of registration to this level. So I think the subsidy is so important to raise the registration. But from now, however, it is now difficult to register past cases. So we have to think about their past cases, past and register. So I think the most important thing is to register and the subsidies. I think so.
Thank you so much. I can see a question in the chat. One of them by Mahmood about the Australian registry. Can other countries join the established Oncofertility Registry in Australia? And Antoinette has said, yes, the registry is open to any country who wishes to join. And they've already got sites in US, India, and Mexico, which is absolutely fabulous. And there's another question in the chat.
Yes, please. Yeah, I just want to, from Antoinette, to highlight this, that it could be a very good opportunity for other countries to join a very well established registry, right, Australia, until they develop their own registry. So can you please, Antoinette, highlight this chance? This is a great one.
I mean, the idea was really, we hosted it on a platform, so it's hosted on Salesforce that's internationally renowned, that has very stringent health and ethical standards. And we have got the opportunity to make changes to things like demographics, where it comes to language, ethnicity, how you report your health status in terms of Medicare and health insurance. They're all things that could be modified. But I think the data set is so robust that we can either collaborate with our colleagues or we can work with colleagues who want to use our registry either as one data set or to say, okay, using the Australasian registry, but only collect data from, you know, an individual country and reporting back.
Yeah, thank you so much. This is really a great opportunity. So Yasmin, please continue your question.
Thank you. I note the time, but there's a couple of comments and questions in the chat. So one comment from George's iPhone, looking at the Oncofertility becoming a global platform, that it shall be a good benchmark for other countries to follow as they make changes to suit their local populations. Great work. So I echo that. That's amazing work. And there is a question: what are currently the biggest hurdles for doctors as well as patients in order to provide fertility treatment to as many patients as possible? Who would like to answer that question? Maybe, Dunja, would you like to answer that?
Yes, I can try.
Provide your perspectives.
I think the biggest burden or the biggest hurdle is really the time schedule. So the infertility centers, for example, in Germany, they provide a special schedule, so a special time slot for fertility preservation patients, for example, 1 hour per day or 2 hours per day. And I think that's very important. So you can't just talk to these patients, I think, in 10 or 15 minutes. That's not possible. And yeah, that's very important to have time for the counseling.
Thank you. And from a pediatric perspective, I would say education, training, scope of practice, you know, the culture within the organization, the resources that the organization has. There's so many potential barriers which are improving all the time, really. So I think
I'd also say referral pathways. We know in the published literature, less than 10% of cancer centers have an established referral pathway. And I think that is probably one of the most critical things, understanding who you should be referring to, having it consistent, so junior doctors, nursing colleagues know who to refer to. It doesn't depend on one person who's a champion, and testing those referral pathways so we know, does it work on a Monday? Does it work on a Friday? Does it work if the hematologist use it or the oncologist use it? It should be really smooth. And where are those referral pathways? So in Australia, we had a significant problem with most of our fertility centres being in the private sector, and we've had to work out ways to have public access. So we're slowly doing that. So I think I'd certainly encourage as a first step centres or cancer centres to start documenting what they have available to them and start those collaborations and conversations with champions, and then slowly building up on that work.
Thank you so much, Antoinette. It looks as though we're right on 11:02 in Melbourne, so I think that's our time. So thank you so much, everyone, for joining us. Thank you for the comments. And Mahmood, would you like me to hand over to you? Thank you to the speakers. They were amazing and very visionary talks as well. Thank you.
Thanks a lot, Yasmin. I think, okay, somebody wants to ask questions? Mike? Okay. Okay, thank you so much for joining us today. It's really great information from great champions in their countries who made great effort to establish their national Oncofertility Registry. So we have a question request from George. Would you like to ask something?
Oh, thank you, Mahmoud. Thank you. Sorry, today most of the time I come late because of the time zones. Sometimes today I had to run and I was taking it when I was driving. I think the talks are quite good, very provocative, and I'm quite happy what they are doing in Antoinette is doing in Australia, in Japan, and Melbourne, and Germany as well. I think those registries are things we look forward for so that we can collaborate. I know in Africa we are a bit behind. We have our own challenges, and we talked about it might be good to get a champion. So probably I hope we'll be seeing you at the Magi and probably discuss it more so that we can have an African maybe oncofertility platform, which will be able to collaborate with the rest of the world. I'm sure there's a lot of data that we have. We also have our challenges in terms of health systems because they are not supported by government. So we have to come out and do it on our own. So I'm sure with Mahmoud and the rest of the group, we should be able to give these needy patients a chance so that their fertility in future is not compromised. But thank you for the talk. I look forward for the next one. Thank you very much.
Thanks,
mine was just a comment. Yeah, thanks, Antoinette. Happy to hear from you. Thank you. I really appreciate it. Thank you.